Yeah, so I'm going to talk today about what and when to refer in terms of young adult hip pain. So I work at the Royal Orthopaedic Hospital in Birmingham, and we're one of the largest services in the country for young adult hip pain. We set the service up about 13 years ago and are one of the biggest contributors to the NAHR database, which collects all the outcomes for hip arthroscopy and hip preservation surgery around the UK. There are some other really large centres as well. There's Oxford, Cambridge, Oswestry, Exeter, Northumbria, London, and I probably missed a couple, but there are some other big centres around the country, depending on where you're based. And we generally see patients aged 16 to 50. And there is some wriggle room in that. Sometimes we see people at the top and bottom end of that if needed, but generally that's our cohort. And we're quite a big service now. We've got 3 consultants, 4 to 5 APPs working in the service, and a number of physios who specialise in hips. I'll just move to the next slide. So today I'm just going to talk about what we want to see really. So screening hip pain, looking at childhood history, typical hip pain in terms of the pathways for FAI, GTPS, OA, when to refer, what to refer and what to consider, looking at version, dysplasia and AVN, and why time is important. Okay, so just moving on to the next. So the majority of hip pain is musculoskeletal and non-urgent, and there's a very small amount that are the red flags, and we generally don't see an awful lot of those because they tend to go off to other places like emergency departments early on. So just from we do get a lot of people concerned about hip pain, but the majority is fairly routine. But if we talk about the red flags first, just to screen those out. So those are things like trauma, so obvious fractures where you'd see a leg length discrepancy or an inability to weight bear. Infection, so if they've had recent surgery and there's general systemic symptoms, or if they're unwell, obviously to suspect infection. And this can be sometimes a number of years after surgery. And often with hips, it's really deep-seated pain. You often don't really see swelling and heat until very, very late on. So it's really that kind of deep pain with a history of an intervention, and injections come into that as well. So it's just having that kind of in the back of your mind. There's also dislocation, which is really rare except in total hip replacements. It's very rare to see really a native hip dislocate unless there's been some quite extreme trauma involved. And that would be really obvious. Again, they'd have shortening, probably external rotation, inability to weight bear. The other group is stress fractures, so that history of overload. And particularly with this group, some hormonal factors might be involved. There might be some diet issues. There's the REDS side of things with the high-level athletes. Oh, sorry, I just skipped along. So it's really just taking in the context of the hip pain and what their physical demands are, what their psychological status is. So, just kind of considering the whole picture in that group where there might be an overload. The other group is the primary bone tumours, and again, they're really rare. They tend to occur really around the diaphysis of the long bone, so looking at the proximal femur or in the cartilaginous regions of the pelvis. Generally, they are a little bit away from the hip joint, so they don't always tend to follow a typical hip joint pattern, but often have a very unusual pattern that just doesn't quite fit. Unless they really develop the more systemic symptoms, they can be quite tricky to pick up. And then following on from that are MET. So if they've got any cancer history, particularly the main cancers that will metastasize to bone, so breast, kidney, lung, prostate, thyroid, and then lymphoma and multiple myeloma. So it's always just worth checking your history with this group. And then inflammatory. So we see very few true inflammatory hips. We obviously check the small joints or any other signs like psoriasis, but it's not very often that we see true inflammatory arthropathy in a hip. Most of ours are, the more kind of labeled pathology as an osteoarthritis. And then the other group are hernias, which obviously can mimic hip pain. So we always ask about cough, sneezing, any obvious lumps, aggravating factors, including things like stomach crunches or when there's a high load in terms of lifting. So it's really just screening those out. So just move on to the next slide. So this just then moves on to other MSK referrals. So in the first instance, anything that's non-MSK, so that would be anything other than what we've mentioned with hernias, but like kidneys, abdominal, appendix, gynae, urinary, and really those are the ones where you're asking about symptoms and it just doesn't sound mechanical. There isn't a weight-bearing element or positional element to it, and you tend to look out for those symptoms of clunking, clicking, and movement that's affected by hip pain, and often those aren't when it's non-MSK. And then the next is lumbar spine. So it's really important to rule out the lumbar spine. It can really mimic a lot of hip pain, particularly posterior hip pain. And it's really identifying if they've got a low back pain history alongside the hip pain, and does it come and go at the same time? Is there anything that's related? And then also, is there any neurological involvement? Most low back pain we see will refer posteriorly, but we do get some that refers into the front of the hip. Often a bit more somatic referral, more rarely kind of L1, 2 region, but it's still definitely worth ruling those out. And there's a few QR codes here for ruling things in and out. So the first QR code is for lumbar spine. The next one is for sacroiliac joint. So that's really looking for any pain that's just not midline, and then obviously has a combination of the pain provocation tests. And again, there's a QR code for that. And we do sometimes see sacroiliac joints that refer again into the hip and are related. Sometimes you can have a really stiff sacroiliac joint, and then that is influencing what the hip's doing, or vice versa. So it's always worth looking at it and palpating it and checking it from a pain provocation test point of view. And then we move on to pelvic related pain. So, is there a history of instability, recent pregnancy? Is there some muscle weakness around that? And asking about bladder function, is there any stress incontinence? And all those can give you clues as to whether there may be some instability contributing. And there has been some research done into pelvic instability and strengthening pelvic muscles that actually then improves hip pain. So there's definitely a relationship between the two. So that's always something we check out. And again, if they've had a C-section or if they've still got a diastasis, they're all things to consider in terms of that central control. And then the other group is hypermobility, which we see quite a lot of really in hips. And typically, the Baton school doesn't really screen hips, so you're looking at other joints. But generally, if they've got a pattern of hypermobility, we definitely need to consider that in assessing their hip pain. And then lastly on this page is multi-joint or chronic pain. So, have they got a long history of pain? Is it non-specific? Does it not fit a pattern? If they've got hypersensitivity, yellow flags, they're all things just to consider, is this true hip pain or is this something else driving it? Okay, and then we'll move on to actually what we really want to see, which is true hip pain. So this is intra-articular pain, and what we find really with the younger group and the very start of true hip pain is it often starts with very focal pain that's in the pointer sign, so very much at the front of the hip, and it can be very pinpoint. And it's described in the literature as a chop sign or pointer sign, and then it can spread into a C sign, and we see that more with an OA presentation. And so I tend to feel that really the more it spreads, the more joint involvement you're getting, but often it will start very, very pinpoint at the front. And this can be aggravated by twisting or deep flexion activities or impact activity. And patients often get locking or clicking or clunking sensations, or they feel they have to move their hip out into a certain position to ease their pain. They often have a loss of flexion and internal rotation, but to varying degrees. So it depends on their activities as to how much that's affected. So with ballet dancers, it might be you go right to the very end of their available flexion to find that pain and to see that there's a difference in their flexion range of movement compared to the other side. And then stiffness. So in quite advanced cases, then, patients start to have difficulty getting their shoes on and off. And that tends to be more than a symptom of OA kind of progression, because it's affecting more of their function. Okay. And so what we really like to see is intra-articular pain in the under 45 group. So they often have pain on flexion and internal rotation, which is revealed on the Fadir test, which we'll go through in a subsequent slide. And they probably have a labral tear if they've got that kind of pain at the front, pain on flexion, internal rotation, and we often correlate that with a pattern of having a labral tear. Not always, but that's often what we find. And just as a start off, if you do pick that patient group up, many will resolve in the first 3 months with just self-management, advised gentle exercise. And so if we go on to the causes of labral tears, there are two main causes that we see. There are the classic bony impingement group that you probably have heard of, the femoroacetabular impingements, where something is causing some catching on the front of the joint, and eventually the labral tears, and that can be a pincer or a cam. And then the other extreme is that we see instability in shear forces that cause labral tears, and that's where there is not enough control, often at the front of the hip. We often see anterior labral tears, and that can be if they're hypermobile, but also if they're unstable. So if they've got some loss of joint integrity, so dysplasia or some other bone morphology, where there isn't as much coverage at the front, and the labrum, which supports the front of the joint, ends up taking more of that force and eventually tears. And so that is the other way that you get the labral tear. So there's two groups, and they're quite distinct. Okay, and so if we talk about FAI syndrome, we'd see that CAM morphology prevalence estimates from 5 to 75% in the population. So CAM on its own isn't something that you definitely have to treat. It's not something that definitely becomes symptomatic at all. And we have to be really careful that we don't jump at CAMs on imaging and say that's definitely where your pain is coming from. And it's just the same with labral tears. Again, in 60% of the asymptomatic population, they can have a labral tear but no symptoms. So it's really treating what you find and making sure that it correlates with their clinical pattern. There's some work on FAI as a syndrome and the terminology of it with the Warwick Agreement, which was done in 2016, if you want to read more around it. And that very much talks about symptoms that fit with labral pathology, so the pain on flexion, internal rotation, but also imaging that correlates with it, and then a diagnostic injection which confirms it. And so really, you really want to only call it a syndrome if you can say that it truly is symptomatic. And then there are other factors that influence FAI syndrome, so their version and torsion and offset. So it's not always as simple as having a pincer or a cam. There are other things that can influence it. Okay, so obviously we've just mentioned it has to be symptomatic. It's caused by abnormal contact between the proximal femur and the acetabulum, causing some impingement on the rim and the labrum, eventually tearing. It's more common in males and females, and there's quite a bit of research about the development of cams, particularly cams more than pincers in the younger age groups. And normally from around 12 onwards, there's the thought that these cams develop particularly in high level impact sports. So in football academies, they've done quite a lot of work seeing that these develop over time and they think it's associated with the high impact that's involved. And there's also some thought that it's actually as a result of the extension of the epiphysis, or potentially a small SUFI. So we still don't really know exactly how it forms and why, but that's where the research is at the moment. And then obviously this can go on to cause a labral tear, like we've mentioned. So it gives pain in the groin, locking sensation, stiffness, limited range of movement. Often after an incident it can happen, so it can be traumatic, but it can also be gradual. And so the traumatic ones can often be more of an FAI, where they've suddenly gone into a deep flexion. And the gradual, what we see, tends to be a bit more of the instabilities, where they gradually are introducing those shear forces repetitively, and the labrum eventually tears. But before it tears, you can experience pain from the synovium, getting really irritated by it. So those again can sometimes separate into two groups. So in order to confirm the hip joint is the problem, the Fadir test and the Faber's test both have really high sensitivity for picking up intra-articular pain. They're really low on their specificity, so it's really hard to say exactly, what is causing that pain within the hip joint. But the majority of the time, what we tend to find is it is a labral tear somewhere around the clock face, as they call it, within the hip joint. There are other structures that can get affected, like the ligamentum teres and the synovium, adhesions, other things like that. But generally, those two tests are telling you that the pain is coming from inside the hip joint, and they're really valuable to do as part of your clinical assessment. And there's just some pictures of how to do those there, and a QR code if you want to read up more on it. And then in terms of the management for FAI, so there have been some really large RCTs comparing physio and surgery for femoral acetabular impingement. And the outcomes of all of them have shown that surgery is slightly superior to conservative management and physiotherapy, but actually both do show benefits in pain and function, which is really important. So particularly the conservative treatment, there's been positive results for pain and function in 39 to 82% of patients up to 5 years. So there's definite value in pursuing conservative treatment first before going down the surgical route. The difference between the two isn't huge, and so actually, we very much push for conservative treatment as the first point of call. And so, which conservative treatment is best? So the evidence tells us that advice and education about joint protection is really important. Movement re-education is probably the most important thing if you've got someone who's repetitively aggravating the front of their hip. So anyone doing deep flexion, like things like rowing, deep squats, badminton, squash, anything where you're lunging repetitively, it's really worth just talking that through with patients and avoiding it, really, to see if they can go slightly more shallow on their squats or on their activities to allow things to settle down. And we get many patients that adapt certain movements and certain sports and completely can manage their symptoms more effectively that way. So a lot of it is patient education. There's some evidence around hip muscle strengthening and core strengthening, and that's definitely the basis of a lot of the treatment that we use at the Royal Orthopaedic Hospital. There's been some work by Joe Kemp's team in Australia that compared stretching to strengthening, and I think that generally the thought was that the strengthening group would outperform the stretching group quite easily. But interestingly, at 6 months, both groups showed improvement in hip quality of life and perceived improvement. So actually, in some ways, it's about really just getting that hip moving, and we don't really know the underlying mechanisms, but definitely stretching has got a place. And I certainly see that in this group, that they can often be very tight, and sometimes you can't strengthen them completely sufficiently without improving their range of movement. So it's definitely in the mix. And then when the recommendations are 6 to 10 sessions of active, personalised and supervised rehab. And this is really important. The personalised bit is, it needs to be individual to the patients. And we get a lot of patients that are given just general handouts, and it needs to be really tailored to the patient's activities and their physical demands, and also the shape of their hip. If you've got someone who's got a very retroverted hip, which we'll go on to talk about, versus an anteverted hip, the movements that you're trying to get them to do will be very different, and the muscles you're going to try and recruit will be different. And it needs to be supervised, because we know that patients do better if their rehab is supervised versus not supervised. So again, all patients should be offered conservative management. And then we move on to intra-articular pain in the over 45. So this group often will have pain on activity, and they tend to have more stiffness than the kind of under 45 group. So there is a slight difference between the label pathologies and the OAs, in that it tends to be more global function that gets affected. They tend to have positive Fabers and Fadirs, But again, a global loss of rotation is more obvious in this group. And they can have stiffness in the mornings, but normally less than 30 minutes. And so the guidance tells us that with anyone over 45 with groin pain, you should suspect OA, and you actually don't need to have an X-ray to confirm that. I think there's some contention about that, and I think, if you have any concerns, then you should X-ray them. But generally, that is the guidance at the moment. So if we look at osteoarthritis and just the process, which I'm sure you're all really aware of, but it's about a loss of hyaline cartilage and chondrocytes attempting to repair and stimulating an inflammatory response, the cartilage breaking down and subchondral cyst development, sclerosis, osteophyte formation. And so these are the patterns that we tend to see, that overall the joint then starts to struggle to cope. And those are just some pictures of grading osteoarthritis. Okay, and then the other group within the OA group is the AVN, so avascular necrosis. And this process can occur actually at a younger age than 45. We see some in their 20s. It actually it has a very different process. So it's really about a lack of blood supply to the femoral head, normally induced by something like a high alcohol use or steroid or chemo use, that causes the process to happen. And so the OA is really the end result, where the femoral head collapses, and because of the incongruity, you develop osteoarthritis. So we often only pick these up kind of a bit later down the line. But if you do have anyone with high levels of hip pain with an unusual history, it doesn't really fit, there's been no trauma, but they've had a history of alcohol, steroid or chemo use, it's really worth having a very low threshold for referral on for this group, because if we can catch them at the early stage, say in stage 1, then there are some surgical techniques that can be used, like a core decompression, or there's some things that they're using at the moment that might be able to maintain the congruity of the femoral head and prevent it developing further. So definitely refer those on if you have any suspicion. And then if we move on to the guidance for OA, so this was the NICE guidance in 2022. For general OA, the guidance is really advice about lifestyle, weight management particularly, and general ways for patients to support themselves. Exercise is really important, and should be encouraged in all patients with OA. And there's some really good work actually going on at the moment in Bournemouth, where they're doing cycling programs for patients with hip OA, and they've had some really good results. So I think if patients are asking about what exercise to do, directing them towards cycling programs or spinning classes in local gyms is a really good starting point for them. And actually the outcomes look great. There's an RCT due to be published shortly. And obviously then there's pharmacology management and other adjuncts. So manual therapy is still in there, and devices as well. So there are other things to consider in terms of their management that can all be managed. Actually, a lot of these can be managed just in primary care, and we don't need to see these really until they get to the point where they want further intervention. Okay, and so if I move on to lateral hip pain, so this is the other kind of large group that we see within the young adult hip section. So this can often present as diffuse lateral hip pain. It can spread down to the knee, and it can be a combination of things really. So the general term is greater trochanteric pain syndrome, but actually it can be a combination of underlying gluteal tendinopathy, so where you get some dysregulation within the tendon. It can also be bursitis, and also external snapping hip syndrome, which we often see in the younger patients who are a bit more hypermobile. And it all tends to get grouped together and called GTPS, which I'm not sure is always that helpful, because sometimes those different conditions actually need slightly different approaches. But generally the advice is to avoid aggravating it. So things like lying on their side, advice about avoiding that, avoiding legs being crossed, and then the sustained standing often can really aggravate it. We see glute med and min tendon pathology in 88 to 98%. That's been shown in some studies. Bursal pathology accompanies tendon change in 20 to 30%, and there's some thought that the bursa is just reacting to that tendon change, and isolated bursitis is rare in about 2%. And ITB thickening can be seen in around 30%. So there's often some kind of combined effect from all of these structures around the greater trochanter. And then there's some tests that you can use to diagnose this. So probably the most useful is the palpation of the greater trochanter. It's got really high sensitivity. A single stand, a 30-second single stand test, again, really helpful and actually has a high specificity, so 97 to 100%. And then there are other tests that you can use as the Faber, resisted abduction, the fader, and the adduction test. But generally, from our point of view in clinic, we tend to use the palpation, single leg stand, and resisted abduction as a general guide to diagnose this group. And then if I just go on to, sorry, if I just flip back, yeah, onto gluteal tendinopathy or GTPS rehab. So we really advise patients to avoid positions of compression, and loading programs are really helpful. So we do a lot of education and talking about load management, make it very individualized. Some patients can't cope with any loading at all, so you start off on really low level isometric loading, and others could cope with much more, and so you can move on to more isotonic, introducing compression when they're ready, and then more plyometric if needed. And so we really, for this group, start with lifestyle and general health advice, load management, physio, and then alternative interventions. So at the ROH, we offer ultrasound guided injections in this group. Again, there's some benefits found with injections, but also shockwave. We've just introduced a shockwave service. And also PRP is also offered in cases where nothing else has worked. And we're very reluctant to offer surgery. The outcomes for hip arthroscopy and debriding the tendons at the moment aren't great. We tend to have about 50% success rate. So we try to avoid that really if possible. So again, with this group, the majority can be managed in primary care, but if you've got a recalcitrant case and it just won't settle at all, definitely refer them in. The other thing that we see with this group is that sometimes there's an underlying reason why they've got these changes around the glutes, and it can sometimes be an underlying hip joint problem that is causing the glutes to get overloaded and sore. So definitely refer into your local hip service if you can't get things to settle down. Okay, so then we're just going to talk about mechanism. So insidious, traumatic, or is this shape abnormality or hypermobile? So if we go back to childhood history, it's a really useful thing to ask about with your patients, and really any shape of abnormality when someone is a child or a baby will really affect the development of that hip and what it ends up like as an adult. And what we know is that when you've got a shape abnormality, you're much more likely to get intra-articular pathology and potentially OA. So the main groups to really ask about is there a history of developmental hip dysplasia, which is when they're born with clicky hips. And most babies these days in the UK are screened for clicky hips. They'll have the clicky hip test, and if this is positive, they'll have an ultrasound scan. And if that shows they've got dysplasia, they'll be put in a harness or double nappied, and that will help the position of the hip to develop and improve the lateral coverage of the hip. And so many of these will resolve, and you've got about the first 18 months for that lateral acetabulum to grow. If it's picked up much later than this, the chances of that improving actually reduce. So it's really important those are picked up at birth. And then following that, in terms of the age frame, the next thing that could have happened to a patient, and they might remember, is Perthes disease. So that's classically in the kind of 4 to 11 age group. We most commonly see them a bit more in the middle of that, kind of around the age of 6, 7, 8. But Perthes disease is definitely something to really consider if you've got, say, an adult presenting with hip pain later on. They may have had an acute episode of pain at that young age, and then it's resolved, and they may not have had anything since, but actually then start to get symptoms later on in life. And we'll just talk about the disease process of that in a minute. And then the same for slipped capital femoral epiphysis. The age range for that is around 9 to 15. And again, we see the majority really in the middle. I mean, 15 is pretty old to still develop a SUFI, but definitely possible. So it's just worth asking your patients, is there any childhood history? Do they recollect any events? And some of these may not have been diagnosed. So again, it's worth just noting those and then having those as a, something just to think about when you're assessing their hip. Could it be one of those if they mention it in their history that they've had an episode? So shape has quite a big impact on how the hip functions. So with a normal hip, you have fairly normal coverage. With DDH, developmental dysplasia, you have a very shallow hip. These are quite extreme pictures, so I'll show you some more x-rays in a minute. But you often have a very shallow hip where potentially in the worst case scenario, the hip can dislocate. We don't see many of those, but that is obviously the worst case scenario. Perthes is where you get a collapse of the femoral head, and that leads to a very misshapen femoral head, and a SUFI where you get a movement up of the proximal femur, and it gives you a bump on the femoral neck, which actually can then cause impingement and ongoing symptoms. So if we look at dysplasia specifically, so dysplasia is quite a big issue really, and really of a lot of interest to young adult hip services, because it causes a huge amount of patient anguish and discomfort really over a prolonged period of time prior to being diagnosed. So the average wait to be diagnosed is about 5 years for patients with dysplasia in the adult population, and they often have a really long history of groin pain and vague hip pain, and it's really hard to get to the bottom of. They often have instability symptoms, and they talk about their hip feeling like it isn't in the joint, wants to pop out, they don't feel stable on it. And they get missed. They go around the surfaces for long periods of time. They sometimes improve a bit because they'll do some strengthening work, which might help, but then symptoms recur. And what's happening with that is the joint is shallow, and the labrum is trying to stabilize the joint all the time. And we often see in this group, when they go in and do keyhole surgery, that the labrum has hypertrophied, so it's thickened to try and hold the femoral head in place and keep it stable. And then the surrounding muscles also get really achy and sore, and that often is what leads to this vague aching pain. There is an association also with dysplasia and hypermobility. So you're much more likely to have hypermobility syndrome if you've got hip dysplasia. And so that, also has a big impact because they're often hypermobile at other joints, which, it then leads to this global picture of instability. On assessing the hip, because you haven't got as much coverage, you have an increased rotational profile. So we test the rotational profile in 90 degrees flexion, and normally it's about 70 degrees overall. You have about 20 to 30 degrees internal rotation and 30 to 40 external rotation. But in this group, it can be way higher, and in extreme cases up to about 180 degrees overall. So, if you've got someone with a really mobile hip, definitely consider if they might have hip dysplasia or hypermobility. And so what happens generally is that eventually the labrum tears and they get very acute groin pain alongside their vague hip pains, and that's often in the end how they're picked up. But what we know is that if these are not treated, then 100% develop osteoarthritis at an earlier age. And so it's quite a big issue really, because we could pick these up way earlier and potentially look at hip preservation surgery, which may prevent osteoarthritis. So if we just go through just some of the risk factors for dysplasia. So it's much more common in females. They often have that birth history, so they have clicky hips at birth, but also most importantly is that they may be breech, and breech position has a high association with hip dysplasia, just because the hip is in a false flex position and it doesn't develop fully, not always. And so if they've got a breech history, and clicky hips at birth, those should be quite big flags to think, oh, they could have had dysplasia. Being the firstborn is also a big indicator. If alongside those other symptoms they're a firstborn and they're female, again, those should kind of increase your suspicion. And family history is also really important. So it comes down the maternal line generally, and so if their mother had hip dysplasia, there is a increased likelihood that they may have hip dysplasia too. We've mentioned instability symptoms, we've mentioned hypermobility, and this group tend to favour things like gymnastics and dancing because they're really good at it, because they've actually got an amazing range of movement when they're young, and so you often find that they do these kind of activities, but also these activities actually keep them very strong. So sometimes if you have someone with dysplasia and they're a high-level dancer, they may actually never present with symptoms until they're in their late 40s and 50s, and they've just maintained the strength around the hip, which has kept them really stable. So that group is something that we just look out for when we're assessing. The failure to improve with physio is really important, and we would say really that, if you have a young female that has had pain for a long period of time and has any of those risk factors and is not fully improving with physio, refer them in, because it's always worth assessing them and screening it out. And if it's not great, and if it is, then there's a chance that we can do something before they develop any wider joint changes. And then lastly, they often present, the routine that we see them is they often present in their late teens and 20s, but like I say, can be later depending on their activities. So in terms of the evidence for dysplasia and what we should do for it, there's some evidence in mild dysplasia, so where the coverage is very slightly reduced, that a strengthening program can help, and that work's being done in Denmark, and we are trying to replicate that at the ROH, where we have a dysplasia class which works on strengthening. And we really advise patients to avoid stretching and yoga, because this stretches the joint more and they just don't really need any extra movement, but we really encourage low impact strengthening. If it's moderate to severe, they really do need a referral pretty much straight away to a young adult hip service. If it's local to us, obviously we'd be very happy to see them. But that's really to consider whether there is any merit in rotating the top of the acetabulum round, which is called pelvic osteotomy surgery, to provide better coverage before they develop any joint changes. And if this, if they're left too long with moderate to severe dysplasia, then it's, highly likely they'll develop that OA at a younger age. There is a consensus statement that's being drawn up at the moment and awaiting publication. And that's just an example of pelvic osteotomy surgery. So they're in this situation, they have cut through above the femur, above the acetabulum here, and then they do a pubic and ischial cut, and they rotate the segment round to provide more lateral coverage, so that the femoral head is more covered. And you can see on the other side that's still dysplastic, and you've still got this area here where the femoral head isn't as covered, and it's still shallow. So that's what pelvic osteotomy surgery looks like. So the outcomes of PAO surgery. So 80% of patients significantly improve their symptoms with PAO surgery, and there was an 80% risk reduction in total hip replacement. So there is a real window to try and do this surgery to prevent them getting OA and needing a hip replacement later on. We know that increasing age is associated with poorer outcomes, and if there's any degenerative change, again, however you move that hip round, the degeneration will likely progress. So we generally don't do that surgery if there's any degenerative change. Just talking through the other conditions we mentioned, so Perthes is more common in boys than girls, age 4 to 8 on average. There's some links to social deprivation. It's known to be a vascular event where you get a lack of blood supply to the femoral head. This causes it to collapse down, and you often get a more mushroom-shaped head. And because of the fact that it's then not a congruous joint, you develop labral tear, which is often how we pick them up later on in life, or OA changes. If you have a young child that you suspect this in this age group, they just need to be immediately offloaded and referred to an orthopedic surgeon for an opinion. And generally they will burn themselves out and the bone will harden up again. And, in many cases they don't actually need surgery, but it's more a case of offloading until it's burnt out. And then SUFEs, so slipped upper femoral epiphyses, are more common, again, in boys than girls. There is some association with an increase in BMI and in retroverted hips. And mean age for boys is 13.5 and girls is 12. Again, you should just immediately offload those on crutches and orthopedic opinion, where in this case they can pin them to stabilize them and prevent them slipping any further. Again, the worse the slip is, the worse the congruity of the joint is, and you get this lack of femoral neck offset. And again, that can cause labral pathology and lead to arthritis. Okay, and then I'm just going to touch on rotational abnormalities. So we've talked about impingements where there's a bony block and that can catch on the hip. And we talked about instability where there's a lack of coverage, but there's also rotation where the joint is rotated more forwards or back. And so if the acetabulum is rotated more back, what happens is that the front of the hip basically becomes more prominent, and this causes a pincer. And so this is a normal hip here, and this is where the front of the joint comes more forward, and it basically causes the anterior femur to catch on the front of the pincer and cause a labral tear. And then the opposite is where the joint is anteverted and it rotates the other way, and you're actually undercovered at the front, and that causes more instability, and in that case you're overcovered at the back. But the anterior undercoverage again can predispose you to a labral tear due to shear forces. So retroversion is a pincer, and that gives you an impingement type tear, and an anteversion is an undercoverage at the front and can cause an instability and then a tear. And so those are all extra kind of nuances to hip pain, and are useful to look out for in terms of, the type of pain they're experiencing, if they're talking about sharp catching pain or if they feel that the hip joint is a little bit unstable. And then the other things that can contribute are the rotation of the femur and the tibia. So you can have anteversion of the femur or retroversion, so rotated in or out, and again with the tibia rotated in and out. And this is probably useful just from a primary care point of view, because if you see someone standing with an unusual foot progression angle, they present with their feet pointing in or outwards, or you feel that there's some kind of alteration in their rotation, this probably should just act as a lower threshold for referral, because there may be some rotation adding to their hip pain that would be useful for us to see, because there are some osteotomies that can be considered in these cases. So just going back to the things that cause true hip pain. So we've got DDH, Perthes, SUFE, femoroacetabular impingement, and rotation abnormalities. And those all can lead to a labral tear, and labral tears can then lead to degenerative change. So that's generally the process. It doesn't always follow. We see lots that don't have labral tears, and we see lots of labral tears that don't lead to degenerative change. And there are many labral tears that aren't actually symptomatic in the population. So just looking at hip alignment, again, just always check position of feet. Are they in or out? Have they got a fairly neutral foot progression angle, or do they walk like Charlie Chaplin or have an in-toeing gait? And then this is just the way that you assess rotation. So in 90 degrees flexion, look at how much they can rotate in or out. And overall, you should have about 70 degrees. Hypermobile patients have a lot more, and retroverted and anteverted hips will have really altered rotational profile. So rotated hips will have loads more external rotation, and anteverted loads more internal rotation. So in terms of what to refer in anything where failed conservative management's happened, including physio, if they've got recurring pain, if there's any rotation abnormality, or they've got really high level sports, or they've got a childhood history, again, have a lower level, lower threshold to refer. Doing a pelvic x-ray is really useful in the community, but probably ask for those things on it, suspect dysplasia or rotation, because sometimes it's useful to help direct the radiologist to what you're looking for. You can definitely do joint injections and MRIs before referring in, but generally we end up repeating them. So if you don't have easy access to those options, then I would just refer in without and just with a pelvic x-ray. MRIs are really useful, and like I say, we will do them. We use 3 Tesla high resolution. They provide the best images of the hip, and we have a number of sequences we like to do. So we do end up repeating MRIs quite a lot. So again, you know, just refer in often without. That's fine. We've mentioned many have labral tears and are asymptomatic. Non-contrast is better for assessment of the chondral surfaces, which is why we don't really do MRAs very much. The outcomes of intervention for the young adult hip surface are dependent on degenerative changes. So that's probably one of the biggest things that influences what we can do. And that's it. So these were just the pathways that we briefly talked about. So labral tear, we often will proceed with the joint injection, hip arthroscopy. If the joint injection is successful, there's evidence it can reduce the development of OA at 3 years in a study done down at Oxford on one of the hip impingement trials. For this group, generally, they need to have a BMI of less than 30 and be less than 45 years old. And generally, the outcomes are poorer if they've got degenerative change. And hypermobile patients tend to not do as well with hip arthroscopy. For dysplasia, we would often proceed with an injection, again, MRI, osteotomy, if there's no arthritis, but again, they need a BMI of being a bit lower, so less than 30 ideally, less than 40 years old from a bone healing point of view, non-smoking, again, poorer outcomes in hypermobility, but good success rates at 5 years for pelvic osteotomies. And then with OA, we would often look at a joint injection if they've got high level symptoms or for diagnostic purposes. Again, for surgery, for total hip or hip resurfacing, their BMI needs to be below 40, and we only offer hip resurfacing in men. There's slightly poorer outcomes if they've got a shape abnormality, but generally hip replacements last really well, 20 to 25 years, 95% of people are happy. Revisions at around 15 years. And GTPS, generally manage these in primary care if you can, but definitely refer in if they're not settling, and we can look at some of the additional options we've got and whether there's an underlying cause. Okay, and so in conclusion, we recommend 3 months of conservative treatment before referring in. Increase suspicion, have a low threshold if there are any of those other elements of their history or assessment that kind of raise concerns, and if they've got persisting pain. Consider age and risk of degenerative change in terms of referring in, because obviously there is a time window to proceed with any surgery with these patients, and try to optimize their comorbidities before referring in if possible, like BMI, what they want from intervention, smoking, ability to cope with any further intervention and rehab. Thank you.
Thank you, Lucy. That was a fantastic presentation. We have got 7 questions.
Okay, yeah.
Right, so what's your view on landmark and imaging guided steroid and local anesthetic use for hip OA?
Well, I think so. We only do them. Under ultrasound and X-ray. And I think we only really do them for diagnostic purposes. I mean, occasionally we do them for symptom level, but we refer a lot for injections just to diagnose whether it is intra-articular or not intra-articular. So yeah, we're in favour of doing them, but really just for those reasons.
And I think a follow-up question again is, what would be your intervals and maximum number of steroid injections that you do for GTPS, especially in chronic and unresponsive cases?
Yeah, I mean, I think probably 3 is the most that we do. we get pushback really from radiology if we refer for any more anyway. And actually, if they've had a great outcome with one, and then, what tends to happen is they get less outcomes as time goes on. So we tend to just start to get a bit cautious about referring for any more anyway. But sometimes, you have really good results and a patient will go away for 2 years and then come back and then want another one. And actually, if it means that they can carry on, we'll end up doing a couple, but 3 probably at the most.
What's your thoughts on the GTN patches for stubborn GTPS symptoms?
Yeah, we haven't got much experience with that. I mean, we don't prescribe it, so I'm not really sure. It's not really in the consensus statements. So yeah, I haven't really got an answer for it other than we don't use it.
Okay, thank you. What's the best way of managing snapping lateral external hip syndrome?
So we see most of this in the hypermobile group, and from my point of view, with the background in physio, I think strength work is the most important thing that you can do for this group, and education about their posture and hanging on the hip and trying to avoid it really. So I think that conservative management is probably the best way to go. We see some really terrible outcomes where these have been released, and so I really wouldn't advocate referring for surgery with them. But sometimes a combination of an injection alongside strengthening can be a useful way to progress these.
And there are a couple of referral ones which I'll maybe let you have a read and reply in the chat.
Yeah.
But there's the last one. What's the recovery timescale for osteotomy surgery?
Yeah, so good question. So so it's quite long. So it's about 6 weeks on crutches, and that can sometimes go up to 3 months depending on their healing. So if someone's not healing very well, it can take a bit longer. We get patients in to hydro for the first 6 weeks because they get really sore, and then they go into outpatient physio after that, and they generally are not really back to normal until about kind of 6 to 8 months. So it's quite a long period, and we generally say it will take about 12 months out of your life. So it's quite a long recovery compared to any other hip surgery. It's the longest. And we really have to counsel patients about that, and whether it's something that they can actually cope with, and they've got support with work, and they sometimes need a window in their life, around kids to actually proceed with it. But yeah, it's probably the longest recovery.
Fantastic. Thank you so much, Lucy.
It's a pleasure. Thank you very much.